Sanbonani babukeli emakhaya, welcome to everyone. Sanibingelela and futhi siyanamukela kulo uhlelo lethu esilithanda kakhulu holistic healthy living, where we teach you about all things health. Remember siyafundisana ukuthi your health is your responsibility, and thina basically into esifuna ukuthi siyenze ukuthi sisizaneni so that we take better responsibility of our health. And so siyakhumbula ukuthi kwamele ukuthi sibonge kuwo ubishop noma bishop wethu for giving us this opportunity ukuthi sikhona ukuthi sifinyelele kini and talk to you about all things health. Kanti ke singakayi ekudeni, just a quick recap. Last week we started with our mental health series. Kanti ke we had a clinical psychologist, Evelyn, where we were just talking basically ukuthi what is mental health, why is it important, why kumele ukuthi sizinakekele ngale ndlela. So today, njengoba besishilo, we have a psychiatrist in the house, and she will be taking us through amanye diseases that were actually seen kuyo the spectrum of psychiatric illnesses. But this is definitely a powerhouse. She is a female, she is a consultant. I am just going to read kabanzi so that you know so Dr. T.C. Nechilema, as I said, she is a consultant. You know, she has she got her training, her undergraduate training from the University of KZN, and this was in 2004. She then specialized, okay, but prior to specializing in psychiatry, she worked for several years as a medical officer. Phela siyakhumbula ukuthi kunama levels into this thing. Kanti ke asebenza kuyo both public as well as private. It was then there that she developed this passion of becoming a psychiatrist. She holds currently a M.Med in psychiatry from the University of Pretoria. She also holds a fellowship qualification with the College of Psychiatrists of South Africa, and she also has a diploma in mental health and from the College of Psychiatry. I am just going to welcome her, and then she will tell us gabanzi about herself. You know, sometimes into, but it is better to hear it from her. So Dr. T.C. Nechilema. Doctor, how are you?
Good evening, Zinhle. Good evening to the viewers at home. Thank you for welcoming me to your show. I'm well, thank you. How are you?
We're very well, thank you. We are actually so glad to have you on the show.
Yes.
Thank you so much.
And I'm happy to be here. Thank you.
That is great. And you know, we're just going to be talking. We're going to be talking, and in us just conversing, people, viewers back at home will actually pick up a thing or two. So, Dr. Nechilema, please tell the viewers, Uguti, why psychiatry? I mean, you could have done so many other things. In fact, psychiatry is not so appealing in other people because they're thinking, oh no, it's mad people, it's mad people. Why did you choose psychiatry?
That's a very good question, and it's a question that one commonly gets. Psychiatry is the neglected discipline. But I suppose, as you said in your introduction, I worked for several years as a medical officer, primarily in the trauma units.
Okay.
And I would see many patients coming in with chest pain. They predominantly come with chest pains. You sit down with a patient, and then it turns out to be an anxiety disorder. And you realize, shame, these patients are suffering, and they actually don't know where to go.
So from chest pain to an anxiety disorder.
You run all the tests, you do an ECG, you do chest x-rays, you do blood tests, everything comes back normal, you present it to the patient, and you're like, tell me what's really going on. And then they start telling you, you know, what's really bothering them. And what stood out for me was that they didn't know where to get help. And I realized that I had a passion for actually sitting down with them and going through what is going on, how can we help. So that's how I ended up in psychiatry. I'm sure everyone has their own story, but that's how I ended up deciding there's actually no health without mental health.
Wow, I love that. Babugeli, there is no health without mental health. That is actually quite key because we, as you mentioned, it is very, very neglected. Why do we neglect it so much? Do we think it's not there?
Yeah, that's a good question. Why do we neglect it so much? There are various reasons. There's the issue of stigma. People
Yep.
see people suffering with mental illness, and they try to distance themselves because you see someone suffering in a particular way, and you don't want to suffer like that.
Yep.
You think if you distance yourself, then almost the problem doesn't exist, but it's not quite that simple. It doesn't only apply to psychiatry. Psychiatry has often been likened to cancer, where similarly patients with cancer suffer stigma because of the disfigurement, because of the suffering. We try to distance ourselves. So psychiatry has similarly suffered because of stigma. But that's something that is changing because as we know more, we teach more.
Yep.
We raise awareness to say, but not all psychiatric disorders are the same. They don't all carry the same prognosis. And in most of the cases, we can actually intervene. We can treat and make the disorders manageable and give the person a chance to lead a meaningful life.
And that is the message we want to bring to the people, that it doesn't just end there. There's something that can actually be done. You don't have to suffer alone, or the family doesn't have to suffer alone, but there are actually intervention measures, babugeli emakhaya, that can actually be done. Njenganomugula une high blood, or you have a some wound that you can clearly see that needs to be taken care of. Ganjalo with mental diseases, there is something that can be done. You go and ubona abodokotela like Dr. Nechilema, where they will actually be able to help you. They can diagnose it, and they don't just stop there. They actually also treat it. So Dr. Nechilema, today we want to talk about depressive disorders, and we also want to talk about bipolar.
Yeah.
Lately, this word depression has been going all around. Everyone is a self-diagnosed, depressive patient, etc. So I just want us to just clarify, the importance with the viewers at home. Let's start by defining it.
Yeah.
What is it?
It's true what you're saying. A lot of people will say, I'm depressed, or that so-and-so has bipolar. But I think we need to be very cautious before assigning a diagnosis to someone. It has to be a trained a person, someone who's trained in the diagnosis of mental illnesses, who is able to make such a diagnosis. If at any point a family member or a friend or an associate is worried, rather say to the person, let's go and see someone, and then we can go through the diagnosis, through the evaluation. But what is depression? Depression is everyone feels sad from time to time. Everyone has a bad day, but depression is more than that. It's more than just sadness. Predominantly, the core symptoms of depression will be extreme sadness. It will be prolonged sadness. It will be for most of the day, for at least many days, and it goes on for weeks, where the person doesn't seem to see the light. It consumes the person. So it's extreme debilitating sadness most of the day. It carries on for at least 2 weeks. Associated with that, we find other symptoms associated with the depression. And for us to make the diagnosis, we look at the sadness in combination with other symptoms. So the duration, it has to be at least 2 weeks. And also the person will have other symptoms such as self-reproach, which manifests as guilt, inappropriate guilt. They might feel guilty about things that they have no control over, but they just feel guilty. A lot of self-reproach. They also have loss of energy, where sometimes they can lie in bed for weeks, not able to get out of bed. In extreme cases, they can't even get out of bed to brush their teeth, so it gets that bad. They also have difficulty with concentration, with memory, with making decisions. They can also be psychomotor retarded. You might find that the person just sits and doesn't seem to have any will to get up and do something. So they can be extremely psychomotor retarded. Also, they can be psychomotor agitated. Okay. They also have an extreme loss of interest. So you might find that if it's someone who's usually an introvert, they now become, if they're extroverted, now they become introverted. They don't want to go out anymore, they don't want to go to the movies, they don't want to have coffee, they have lost interest. If it's a student, they don't want to go to class, they don't want to study. So that loss of interest, together with the depression, together with the insomnia, the psychomotor retardation, and also they lose appetite. They can even lose weight. The opposite can also happen, where they seem to eat more.
Eat a lot.
You know, some people eat more and then they put on weight. And also sleeping, they don't just lose sleep. Some people just sleep more, like sleep all the time. So those are the symptoms, and we have to look at the criteria that the sadness has been present. It's not just normal sadness, it's depression for 2 weeks, together with at least 4 of the symptoms that I've mentioned together. And also we find that they tend to have a hopelessness about it as well, where they don't see themselves getting better, they don't see their situations getting better, and they also have recurrent thoughts of suicide. And that's where depression becomes quite dangerous.
When you're having the recurrent thoughts of suicide.
Yes, so that's one of the biggest problems that we see. But even prior to that, the person's functioning is impaired in terms of social interactions. If they have a family, they are unable to meet the social demands of being a parent, being a wife, you know, running a household. But also occupationally, they can be impaired. So depression is quite a debilitating illness if it's not recognized and it's not treated.
Wow, Babugeli, that was a mouthful. Mara udokotela uyi-explain kahle ukuthi uzwisise kahle kahle ukuthi sikhuluma ngani. So doc, are we saying it's okay to be sad? I may feel sad from time to time. That is okay.
That's normal. We are human beings. That's what makes us human beings. We have emotions. We are emotional beings. It's okay to have a bad day. Even in patients who suffer from mood disorders, even if they're controlled on medication, they will still have their bad day. But that's okay. We have to separate that from an illness. If someone is depressed all the time, most of the day, several days, then we know that, you know, we need to screen this person for depression.
Babugeli emakhaya kubalulekile ukuthi sazi ukuthi you must just be able to pick up you need to mawubona ukuthi there is a problem, it is no longer normal. That is when kumele ukuthi umbukeli enze njani, you go and you seek help. Kanti that is what we're trying to bring to the show. We need awareness so that you know ukuthi when should you go out there and seek help. Ungahlali usafara, ungahlali and having problems ucabanga ukuthi no man, it will go away, or no, as in I just need some time. No, go out there and seek some help. Now doc, the next thing that people are probably wondering, who gets this? You know, should you be, and by this I mean the socio-economic spectrum, the status of a person. You know, if I'm maybe, for example, poor and I'm not okay, am I more prone? Or even if I'm okay, let's say I'm fine, I'm doing okay, I may not be there, but I'm doing okay, can I also get it? Is it more prone to males? Is it females? Like, can you just give us, you know, like from what you have seen, from your experience in all the years that you have been practicing, and also very specific to our country, what have you been seeing?
Depression is common. Who gets it? Anybody can get it.
Right.
And you know what caused the depression? It's a combination of factors. We know there's biological factors, and that includes genetics, if there's a family history. Psychosocial factors, what's going on in terms of you psychologically. What kind of stress are you in? Socially, what kind of circumstances are you going through? For instance, someone can lose their job, they can lose their marriage, they can suffer a loss, a bereavement. So anyone can get depression.
Anyone can get depression.
It's common. It's very common. It's actually the most common psychiatric disorder. The prevalence can range from 10% in the general population. So that's 1 in 10 people.
Yep.
Have had depression at some point in their lives.
Wow. 1 in 10
1 in 10
people.
1 in
So
10.
Babugeli, if land kona company 10, one of you guys, so it's that common. It is that common. So it's, I mean, are you weak? Are you a weakling if you find yourself going through, a depressive episode? Because sometimes, you may think, okay, maybe I'm weak, maybe I'm not good enough.
Yeah. That's the depression talking.
Oh, that is the depression
that's what
talking.
happens when you have depression. That's what happens when you have
Okay.
depression. You start having the negative self-view, the self-reproach. Anyone can get depression.
Okay.
But obviously it's more common if, in someone who's vulnerable, like in terms of genetics, psychological makeup, social factors as well. But it's very common. In some settings, it can be as high as 30%.
Wow.
We do find that it tends to be more commonly diagnosed in women than in men.
Okay.
However, we also know that many men don't present for treatment.
Oh.
Many men actually self-medicate. They might self-medicate with alcohol, with other substances, with caffeine. Many men self-medicate.
So they may use other means to try and deal with that. So they're diverting it basically to something else.
Yes.
Wow.
We diagnose it more commonly in women. And in terms of age range, it's usually people in their 30s who present with depression. And it's easy to understand because that's when the demands of life also are adding up.
Yep.
There's the career, there's the work, job satisfaction might be low, marriage difficulties, and so forth. We are also finding that the incidence appears to be rising. We are seeing more and more depression. The South African Depression and Anxiety Group actually reports that the incidence is on the rise, and there are many reasons for that. We have smartphones nowadays. We are almost always on call, always alert. There's never a chance to switch off.
Yep.
So people are not really equipped to deal with this old technology, the work demands and everything. But it's more common in women.
It's more common in women.
Women in their 30s.
Yep.
It can be diagnosed in children as well.
Okay.
But they tend to present slightly differently.
All right.
And if it's diagnosed earlier, it tends to run a worse course.
Oh, okay.
It tends to run a worse course. We can also diagnose it in the elderly. And then also it's difficult to diagnose because they tend to complain more of somatic symptoms. Bodily aches, bodily functions not okay. And it's important that we keep that in mind because it can also herald the onset of other problems such as dementia, major neurocognitive disorders. So no age group is spared.
That is, and I think we want to emphasize that no one is spared. So just because Dr. said that it's more common in females that are in their 30s, just because you're a male and you're 35 or you're 40 or even younger, agushuguti, you may not get it.
Yes.
Okay.
No age group is spared. No social economic group is spared. It's found in all socioeconomic groups. It's found in all races.
Yep.
So it's common. It's common. It's debilitating. It warrants treatment.
Now, moving on to that, doctor, what can be done?
What can be done? What can be done? Firstly, we have to recognize it.
Okay.
And the common mistake that people make will be to say to a person suffering from depression, you snap out of it. Just snap out of it. Rather not do that.
And that goes around a lot, especially in the times we're living in. There's so much pressure, Ibo, move, that's what we're all about. Move, heal, those kind of terms that are, heal, sis, just heal and move on.
Just heal. People make mistakes when it comes to managing someone with depression.
Yep.
This is an illness. we don't fully understand it. We know that it's a brain disorder, but it affects the whole body.
Okay.
It affects the whole body. It affects lives. It warrants attention. So the one thing that we need to do is we need to recognize from the description that I've given someone who's potentially ill, and then bring that person to medical attention.
All right.
They will be assessed.
Okay.
They will go through a thorough assessment. A psychiatrist or a psychologist or a GP will go through an assessment. It's typically a clinical interview. They interview, they screen for symptoms. They might ask the person to complete a questionnaire, like a patient health questionnaire or something along those lines. Examine the patient physically, and also just check for other comorbid disorders. But once it's diagnosed, then depending on the severity of the illness, the psychiatrist will then decide on what treatment to recommend. Okay. The two main treatments that we recommend are pharmacological agents, that's medication.
Okay.
But there's also a second arm, which is psychotherapy. We find that the best response is when we combine medication with psychotherapy.
Okay.
And we tend to treat depression in a team setting, because there's a psychiatrist who mainly brings the medication part of it. There's a psychologist who brings mainly the psychotherapy part of it. But remember, I also mentioned that they have occupational and social impairment. Then occupational therapy becomes important as well.
Okay.
They might also have social difficulties. Then a social worker also is important in terms of addressing. And in some cases, if it's very severe, we might need to hospitalize the patient.
Okay.
If they're not able to look after themselves, if we find that they are at risk of, of harming themselves, neglecting themselves, or a risk to others, then we sometimes have to hospitalize them.
Now, Doc, I want to know, is there a place for, maybe, I don't have social support as in like family, and, because yes, I may be the one that has the illness, but it doesn't just affect me.
Yes.
Is that correct to say?
That's
It
true.
also affects the people I live with, or,
Yes.
my surroundings.
Yes.
So is there a place for them in the intervention? Are they ever maybe brought in just to make them understand, this is actually an illness and how to go about with it? Or,
yeah, that's actually a very good question, because you can imagine living with someone who suffers from a mood disorder. The instability of the mood, it does cause problems in those around the person.
Okay.
And if one finds themselves caring for such a person, then I would encourage that person to learn as much as they can about the illness.
Okay.
To even go with the person, to volunteer to go with the person to their doctor's appointment, ask the doctor to explain, so that you understand and you're on the same page. And it's also important for the person looking after the person with the mood disorder to look after themselves as well. To perhaps take turns, get relief, and also to join support groups. There are often support groups either in the hospital or in the community, or if there isn't one, then you can start one. You can start one, and it helps.
Change always starts with us, Babugeli. If ingekho, you make it happen.
Yes, because it's important to share experiences, and also to have people who have been through something similar in terms of what can you expect.
Wow. Now, Doc, you just said, if I'm taking care, it's okay. If I am one that takes care of another, sometimes I may need a break. Or now one may ask, Aibo, is it contagious? Nah, could I, why do I need some time off? Or could it just, abanye abantu bathi iyathelelana, could I just get it?
No, it's not. It's
not at all.
No, not at all. It's not contagious. It's not catchy. It's just to remember that one needs to look after themselves if they're going to be able to look after other people. Support groups become very important, and social networks are very important as well. Yeah, but in effect, depression is a treatable illness. It's a treatable illness, and it's quite amazing. We find that if you start someone on antidepressants, they typically respond within 2 weeks.
Wow.
Within 2 weeks, perhaps up to 4 weeks, they have responded.
But definitely, Babugeli, this is what we want you guys to know. This is what we want to share. Uguti, yazini, you do not have to suffer alone. You do not have to see your loved one suffer from depression and think, Uguti, that's it. There is actually something that can be done. Kantige, siyafuna ukumbuzana, Uguti, we will be opening our lines soon. Lapho nizokhuluma naye udokotela and ask questions. You know, eze izinto mhlawumbe ongakubambanga, so asilungise namafoni, asilungise nama-airtime, lapho besesikhohlo yazini sale sowutewetsa masinya nje ukuthi uzokhona ukuthi ubambane nathi eqingweni phela ngithe siniphathele i-consultant. So yay babukeli, asibeni ready ukuthi-ke senze kanjalo. So doc, please quickly let us go into bipolar. But before we get into that, you know, when one hears bipolar, it's like, yahlanya lo. That in layman terms, it's yahlanya. And now we don't want that, you know. We don't want, one of the things we want to really, you know, the stigma around such and saying such words like, yahlanya. Why would I then want to go, like, who wants ihlanya? Who can help ihlanya? I mean, ngihlanya, so let me just be. Please tell us, what is bipolar?
Yeah, shame. You know, lay people will think that all craziness is the same.
Yep.
But our patients are not crazy. Patients with bipolar actually are very high functioning when they are well.
Okay.
When they are well, they are very extremely high functioning. Majority of them even have jobs. They can be nurses, they can be doctors, they can be lawyers.
Really?
Yes, they can be teachers. I've treated patients who had professions.
Yes.
When they are well, they are very well. So they're not crazy, not at all. But you know, let's unpack what bipolar is.
Yes.
It's different from unipolar depression. What I was describing initially is what we call depression, but it's unipolar depression, right? Which means it's on one pole.
Okay.
Bipolar depression, on the other hand, you know, the name sort of gives it away. It's bipolar, 2 poles. So the person has episodes of extreme mood changes where they can have extreme highs,
All right.
which can also alternate with extreme lows and sadness, and back and forth. Extreme highs and then back to hopelessness and sadness. So they can have these extreme highs, which are not normal excitement, no. Those are abnormal, they're out of the ordinary.
Okay.
Even for the person and those around the person, they are different. They are abnormal, and I'll go through the features now of how to recognize it. In between, the person can actually be fine. In between episodes, the person can actually be fine. So they're not crazy. They have those episodes, which are episodes of illness, either the extreme highs or the extreme lows, hence the term bipolar, because they are in between 2 poles. So how we diagnose it, a person, to qualify for a diagnosis of bipolar, they must have had at least one manic or hypomanic episode.
Okay.
And that's the high that I'm referring to.
All right.
So a manic or hypomanic episode, the person has an extremely abnormally happy mood. They're elevated, they're elated, they're on top of the world, nothing can get them down. They have all this energy, extreme energy, very busy. They have a decreased need for sleep. They feel rested after just a few hours. They don't need sleep.
Oh, wow.
They are extremely talkative. They have ideas running through their heads so fast. Even when they talk to you, you might find that you struggle to follow the conversation because they can jump from one idea to the next. They're extremely distractible. So you can see, although they feel great, it's going to be very difficult for that person to be productive, hey? Because, you know, they are distractible. They're talking very fast, sometimes not making sense, not sleeping. And it usually ends when the person becomes depressed. It usually ends with a depression, or they can become exhausted and get admitted to hospital. Now, for everyone gets excited, especially if they've heard some good news.
Yes, definitely. Or money. Money makes all of us happy.
Yes.
Suddenly, you're on top of the world.
Yes. But the difference between that and someone with bipolar is it usually is not related to what's happening in their environment.
Okay.
It usually just comes spontaneously. Nothing has happened, then they just have this up.
All right. Okay.
And it tends to last longer. You know, if something has made you happy, you'll be happy and elevated, perhaps for a few hours, maybe a day or two. But they just keep going. And for the diagnosis, it has to last a week. For it to be a manic episode, it must go on for 7 days.
Okay.
Or sometimes it's so severe the person gets admitted to hospital.
Wow, and they've been on a high all this time.
They've been on a high.
They've been on a
Yes.
high. Okay.
Not sleeping. So for a person to be diagnosed with bipolar, they must have had that at least one high. They might subsequently present with depressive episodes,
Okay.
but we must keep in mind this is a person who has had a high because we treat them differently.
Okay.
We manage the condition differently.
Okay. So, Doc, you know, as we said, there are many things that can bring one on a high. Maybe someone says, okay, but usually when I take this or I drink that or I go on a high. We're not talking about those kind of highs.
No,
Okay.
no. It's, you know, you're mentioning substances. Yeah. Let's go through what is in a manic episode. You know, it's the extremely abnormally elevated mood. They're distractible. Sometimes they're irritable instead of happy. They have a decreased need for sleep. They have this pressure to keep talking very fast. You know, ideas changing very quickly. A lot of energy. But sometimes they also have, you know, grandiosity. You know, instead of more than just feeling good about themselves, they might even become delusional, grandiose, where they lose touch with reality. And they can sometimes just come and say, I'm the president, or I'm a gazillionaire, or I'm a billionaire, or whatnot.
Yeah.
But also, part of the criteria is that they have increased impulsivity. They might engage in activities which have a high likelihood of negative consequences. You know, that includes gambling. That includes substance abuse. I'm bringing it to the substance abuse.
Okay.
To say substance use is common, and it works both ways. It can induce an episode, but it can also be the result of an episode.
Okay.
We do see mood changes related to substances, but then that will be, you know, bipolar disorder due to substances. We do see that, but also we do see that there's a correlation between mood disorders, bipolar disorder, and substance abuse. It's quite common. About 60% of them also abuse substances, and it tends to have a negative effect on the illness.
Okay, Doc. So now, who gets it? Who gets it? If maybe I have a family member that has had it, are my chances higher? Does that mean I will get it? How can I prevent it? What can we please go through that?
Who gets it? It's not as common as depression. About 1%, only about 1% of the population present with bipolar. The causes are also multifactorial. It can be biological. There we're looking at genetics. It can be psychological. It can be, you know, social. But we find that bipolar disorder definitely does have a strong genetic component.
Okay.
So, you know, oftentimes there's a family history, but there might not be a family history. And just because someone in the family, let's say a parent has a child, a parent with bipolar has a child, it does not necessarily mean the child will get bipolar. There's an elevated risk, but not necessarily the child will get it. Other factors come into play as well. But definitely bipolar does tend to run in families.
Okay. Babukeli emakhaya ngifuna ukuthi nginikhumbuze ukuthi isikhathi ebesesilindile sesifikile. We are opening our lines so that you can reach us from where you are at. Kanti ke asikhumbuleni ukuthi the number to call is 011-676-6836. Mawungayibambanga ngizoyiphinda, thola ipeni, thatha ifoni, inumber ithi 011-676-6836. Asevuliwe ke amalayini kanjalo sithi seningafona nisibuze imibuzo that you want to know. While silindile sizoqhubeka ke, Doc, while we are still on bipolar, we talked about who can get it. And we said, yes, there is a strong genetic component to it. Could we say there is like a trigger, a specific trigger? Anything can trigger it. Like I may be fine all my life and you know, there's just that one thing that happens and then there it is.
Yeah, bipolar is definitely, it definitely has a strong genetic component.
Okay.
And it tends to typically present in young adults, either late adolescence or early adulthood.
Yep.
Although we can diagnose it in children as well.
Okay.
We have seen it in elderly as well, but it's commonly associated with another medical condition. It occurs equally in men and women.
Okay.
Although men have been found to present more with manic symptoms, and women tend to present more with depressive symptoms. But both sexes, both genders do get bipolar disorder as well.
Once again, Babugeli, no one is spared. You know, Doc, we tend to say that, in fact, mental illnesses are more of a woman thing. Siyabona ukuthi ama-colds ayangena sizowathatha siyawathatha. It's usually more a men thing. Please, as we take the callers, can we just, can you go through that and we go through it afterwards? Ukuthi, you know what, mental illness it's not necessarily more a woman thing. Kanti, we're going to take our first caller. Sanbonani usemoyeni.
Hi, this is Theo speaking.
Hi, Theo. How are you?
I'm good, and how are you?
We are very well, thank you. Utokotela Ukona, you can address your question right away.
All right. My question is based on the topic of depression. And as I've been listening to the show, it occurred to me that, let's say, like, as a person who is unemployed currently, and I have these symptoms of depression, is it possible to attempt and to actually succeed in dealing with the root of depression without seeking professional help because of obstacles such as cost of traveling to the professional psychiatrist and actually paying to actually see one?
Okay, thank you very much for your question. Please stay tuned to the show and we will definitely address your question. Siyabonga kakhulu. We will be taking the next caller. Siyabong. So, Doc, we will take more questions so that we have a lot of questions that we can address. Sawubona usemoyeni?
Sawubona njani?
Siyaphila ninjani?
Ngikhona. You're speaking to Nonkululeko, no?
Nonkululeko, yes.
So yeah, I have a question concerning the depressive disorders.
Okay.
So the doctor mentioned that it has to be extreme sadness that's like more than 2 weeks. Okay? So my question is, here you have this person, you can see that they've been sad, but it hasn't been more than 2 weeks. Okay? So they are sad, say, for like a week, but they also have other symptoms, like they have short-term memory loss, they've lost interest, they've gained or lost weight. So basically they don't fulfill the criteria for them to be diagnosed with depressive disorder. So my question is, what can be done for those patients?
Okay.
Like, yeah.
Okay, thank you so much, Sakela Uguti. Please stay on the show and then Utokotela will be addressing the questions shortly. Siyabong. So, Doc, the first question, Uti Umbugeli, because of financial constraints, psychiatrists are specialists, they are expensive. I may not, she mentioned Uguti, in fact, currently she's unemployed.
Yeah.
And, but you know what, she wants help, but I do not have the financial means. What can we say, Ngalok?
Yeah. It's unfortunate, and what the caller highlights is actually what we see, because there's a bi-directional effect between life circumstances and depression. She's saying she's unemployed, hence she can't access treatment. However, not receiving treatment makes the likelihood of not gaining employment higher. Wow. So there's a definite need for this person to receive the treatment that they need. Otherwise, they can easily spiral downwards and the hopelessness becomes worse and worse. I would recommend that the person start with their general practitioner. If they're unemployed, they can start with contacting a public, someone in the public service. We do have mental health services in the public sector, by the way. There are clinics that offer free psychiatry and free psychology services. I don't know where the listener is based, but I would encourage her to present to a general practitioner as usual, and discuss, these are my symptoms, I'm worried. A general practitioner can prescribe medication. If the services are available or there's a need, they will refer to a psychiatrist and a psychologist. It's of utmost importance to get treatment, because one improves one's chances of recovering, and then gaining employment, and then things can get better.
Wow, Mbugeli, siyathemba ukuthi uyizwile impendulo yakho. There are actually public facilities la ungakhona ukuthi usizakale khona. Kanti udokotela is stressing the importance ukuthi go and seek for help, because doc, she mentioned ukuthi, can I do it on my own without going to a qualified person to treat me? Can I actually get through this on my own?
No, it's not possible. It's one actually needs treatment, because the whole reason why she is depressed is because she couldn't do it on her own, not through any fault of her own, because this is an illness. And let's not discriminate against mental illness. It's like if someone has, what example can I give? A pneumonia. Why don't you get it better on your own? It's the same thing. This is an illness. You require treatment. Services are available. Let's utilize them. Let's utilize the services that are available. They are available because there's a need. There's a lot of scientific evidence to back up that this is an illness. And no, you cannot do it on your own. If it has progressed to a point where you are depressed, you cannot do it on your own. Let me just give you an example of what happens if you don't treat depression. If depression is untreated, the first episode will likely resolve after maybe 6 months, 6 months to a year. But I've said if we treat it, within 2 weeks to 4 weeks, you're feeling fine. You are feeling better. You are good to go. Is it worthwhile to sacrifice those many months where you're not able to enjoy anything, not able to function? No, it's not. It's definitely worthwhile to utilize the services that are available. And also what we find is, if a depression is not treated, it lasts longer and it becomes more difficult to treat. Treatment works better if it's initiated early. If it's initiated early. And remember, there are different modalities of treatment, depending on the severity. If it's mild depression, one can get away with just psychotherapy, perhaps problem solving, perhaps supportive therapy, and people can actually get better. But you can't do that on your own, unfortunately.
Wow, Mbugeli, siyathemba ukuthi siyakuthola sonke lokho. You know what? Let's rather just go. Kunabantu, they trained for this. Bafundile ngalokhu. They've got experience. Bakhona ukuthi bangasisiza. Now, can we move on to the next question? The next question. So the caller says, maybe what if it wasn't, it's not more than 2 weeks, but yes, I have other symptoms, like I'm losing interest in the things that I'm doing, etc., etc. Maybe I may not fully meet the criteria.
Yes.
What about me?
Well, that's a good question, because we don't want you to wait until it's been 2 weeks. I mean, if you're suffering now, then get help now. Because, the topic for today is depression. So I covered just depression, but there are also other disorders that can present with depressive symptoms. And I'm thinking of an adjustment disorder with depressed mood and anxiety. I'll give an example. If someone has recently lost their job, that person can present with depressive symptoms. You don't have to wait for 2 weeks. If you see the person is suffering, the person is struggling, that's reason enough to go and consult your general practitioner or your psychologist. The person might not need medication. It really depends on what they find on assessment. So no, you don't need to wait. As long as the person is distressed, that's reason enough to access services.
Wow, siyathemba ukuthi nikutholile lokho babukeli, kanti futhi anginikhumbuze ukuthi the number to call is 011 676 6836. Keep the questions coming. 011 676 6836. Now, Doc, another one may ask, okay, Doc, you just mentioned Uguti, if I don't treat it, you know, the first episode may last for like 6 months, but if we treat it, you know, within 2 to 4 weeks, there's response to treatment. But now, how long will I have to take it? After the 2 to 4 weeks, am I good to go? Like, is it fine? Can I leave it and continue with my life?
Yeah. So I'm going to mention for both, for you individually. Let's start with depression.
Yes.
The first episode of depression, typically you feel fine within 2 weeks, 2 to 4 weeks. But treatment is recommended for at least 6 to 9 months. And the reason for that is we know there's a real biochemical change associated with depression. And the medication that we give tends to restore those neurotransmitters that have become depleted. So even if the person is feeling fine, as soon as they stop their medication, they are likely to relapse. They need to continue the medication for at least 6 to 9 months after they feel well. So no, the treatment duration is at least 6 to 9 months for a first episode. But we also find that these disorders tend to be chronic. Majority of patients who've suffered one episode will suffer another episode. So it's not unlikely, it's not uncommon to find patients remaining on medication for longer. And there's no shame about that. There's no stigma about it. What we should be aiming for is recovery. That's what we should be aiming for. So the first episode, minimum treatment duration is 6 to 9 months. Please do not stop your medication on your own. If you're experiencing side effects, please discuss them with your healthcare provider. They have other medications that they can switch to. They have ways of helping you with side effects.
Can we just quickly take our next caller? Sawubona usemoyeni.
Hello.
Hello, how are you?
I'm good, and yourself?
Very well, thank you. Who are we talking to?
You're speaking to Noma Sonto.
Noma Sonto, welcome.
Thank you.
Yes, ma'am.
Okay, so I would like to ask, like, let's say you notice someone in your family, especially with elderly people, maybe it's your parents or your grandparents, like if you notice that they have been feeling constantly sad, they're feeling constantly down, but they're still functional, so it's not at a level of depression yet, but it's been happening for a very long time. Like, if there's something that you can do to treat that, but it's not depression yet, but they're constantly feeling down and you don't know how to help them.
Wow,
Is
thank
there
you.
something that can be done for, like, maybe elderly patients or any family members or anyone that you notice has been feeling down for a very long time, but you don't think it's depression yet, so.
Okay, thank you very much, Mbugeli. We will definitely be addressing umbuzo wako. Siyabonga kakhulu.
All right, thank you.
Thank you, Doc. Elderly.
Yeah, so the listener raises a very good question. Thank you for that. So some people are different. People's functional reserves are different. Some people can suffer extreme distress and still manage to put on a brave face, get on with the job. That is dangerous because the person is suffering in silence. And that is difficult. If the person is depressed and they're still managing to hold it together, big up to them, but they still deserve treatment. I would still say, I'm worried, you know, perhaps let's find someone to talk to. Let's talk about appropriate places where one can start to seek treatment. It's typically your primary care physician, that's your general practitioner. You can present to them and say, I'm worried, my grandmother is always sad. Alternatively, if you know a psychologist, you can go to them and start there. they will always involve a psychiatrist if there's a need for medication. But let's be very aware, some people can still, on the surface, appear to be okay. But when we dig, we find that the person is actually doing all of this whilst suffering extreme distress. It's unnecessary. And if we look even further, we'll find that, yes, the person is suffering, but there is impairment. It's just that they're able perhaps to compensate because of perhaps higher functional reserves.
So, Doc, we're saying to the listener at home, go out there, seek help. Yes, it may not be.
Seek help anyway.
Seek help anyway.
Seek help anyway because the suffering is not necessary. The person is suffering is unnecessary. Let's reduce the person's suffering.
Wow, Babugeli, ngiyathemba ukuthi siyafunda, we are learning, and we won't just stop there. You know, after so zwile, after so fundile, we're actually going to implement what we have learned. Kanti, we're not just gonna stop there. What we know, you share. Angithi singasabi si valela all the information kuthina. Kanti ke we have 5 minutes left before sivala konke sivalelisa. Mara, you know, sizothi, doctor, please, if there is anything I need to remember from all that we have said today, what are doctor's closing words kubabukeli emakhaya?
Mental health is a serious issue. It essentially affects every aspect of one's life.
Yep.
It warrants treatment, and majority of these disorders are treatable. Albeit majority of the times they remain on medication chronically, but they are treatable. It's very important to seek help and to get the treatment that is needed.
Babugeli emakhaya nizizwele. Seek help, seek help, seek help. Now, Doc, we still have a minute or two to chow. Many myths. Is there any one myth that you would like to address today pertaining to mental health as a whole?
Well, there are several. One is if you have depression, you are weak. You know, you have a defect of character, you are lazy, you are this. That's not true.
Okay.
It's an illness. It needs treatment like any other illness, right? It's an illness. Let's accept that. Bipolar disorder, they are crazy, they are not crazy. They have an illness. In between episodes, you will be surprised actually how well they function. Wow. And with correct medication, with consistent taking their medication, they actually remain well. Another one that we need to debunk is this caused by witchcraft or has something been done to you? No. No. This is an illness. We have, we have a large database of scientific evidence to suggest this is an illness. Let's treat it as an illness. Let's get treatment.
Yes.
Just like with diabetes, with hypertension.
Exactly.
We treat those, let's treat mental illness as well.
Wow. Babugeli, it is very important to we run with what the doctor has mentioned. I need to you go and you collect your chronic medication for diabetes every month. I need to see a fola la clinic is your landa. I'm a pilisue to ama ARV na lawa hypertension linje gonke siyahamba siyokulanda. It's an illness. Again, I bang loyeng diabetes. We do not say that. So with mental health, with mental illnesses rather, masingathi ukuthi bangiloyile. The same way mawune diabetes angeke uzuthi bangiloye nge-diabetes, kanjalo with mental illness. There is something that can be done. Let us stop ukuthi sibukele abanye phansi. You are not weak woman out there if you have depression. The men out there, the fathers, the breadwinners. Sometimes, doc, they're even afraid, like, because let's say I am a breadwinner, I can't afford to look weak, I can't afford to be depressed. I suppose other people may probably think, if my employers know, I'll lose my job because I have bipolar, or I'll lose my job, like suddenly I'm not competent enough. So please go out there and seek help. Dokotela, just one more question. Someone may be asking themselves, you know what, a psychiatric hospital, they probably thinking, people are on trees there, bona, it's just a mess. Like me, if I'm fine, I can't go there. Yo, they're gonna attack me, etc., etc. And some just don't want to go. Like, I'll self-medicate because yo, ngizohlangana namahlanya and yo, mina ngihlanye, or, please, doc, you work there.
Yes, I do.
You work there, and look at you. So please, let's encourage, or rather, try show them a different perspective of if I were to go to a psychiatric institution, kunjani?
I would actually venture to say that getting your mental health attended could be one of the best investments that you make, because that's investing in yourself. And as we said, yes, depression is a brain illness, but it affects the whole body. In terms of what these hospitals offer, it's quite amazing. You get proper healthcare, you get to see a doctor, you get to see a psychologist, you attend occupational therapy, you recover. The whole focus is on recovery.
Okay.
There's no better investment than that one can make.
Okay, so I won't come out worse.
No.
Babugeli, I
No.
hope sibambile. Angeke uphume uwes. Angeke uphume uwes. Kanti-ke, Doc, from our side, we would like to say thank you. Thank you for your time, and thank you for teaching us and everyone out there more about depression, more about bipolar.
It's been a pleasure. Thank you for having me on your show.
Thank you so much.
Thank you to the listeners at home.
Siyabonga-ke kakhulu babukeli, and just like that, it is a wrap. Kanti-ke next week siyaqhubeka futhi kuyo lolu daba, but now we're taking a twist to it ukuthi, you know what, we are going through a pandemic of COVID-19. Asikakhohlwa, asikayikhohlwanga, sizoqala-ke ukuthi manje nayo sikhulume ngayo, and how are we dealing mentally? Definitely iyas affect us, so sizobe sikhuluma ngako ngeviki elizayo. Kanti from our side, we'd like to say thank you so much for staying tuned. Siyabonga ukuthi nihlanganyele nathi, and to actually, this is the first step in you taking responsibility of your health, because you need to know, umungazi, there is nothing that you can do. You will not be able to make changes. So the first step is ukuthi wena wazi more about your health. Kanti-ke from our side, sithi singakhohlwa, while we are going through this pandemic, do not forget to sanitize. Imask, you need to have it on ngaso sonke isikhathi. Take care of yourself. Asihlanganeni futhi ngeviki elilandelayo. Thank you.
Madoda, sesifikile leso sikhathi sonyaka. Siyazi ukuthi njalo ngoJuly siba nenkonzo enkulu yamadoda, lapho kuhlangana thousands and thousands amadoda lapho eGNF bakhamba kwindawo ngokwahlukana. Kodwa kulonyaka ka2020 ngenxa ye-lockdown sizabe siyibambe live ku-GNF TV, kanti futhi sizabe si-live ku-GNF TV YouTube channel, kanti futhi sizabe si-live ku-GNF Ministries Facebook page. uNkulunkulu anibusise madoda, sizabe sinezikhulumi ezahlukeneyo, kuzabe kwakhiwa indoda. Ungaphuthelwa, wenze sure ukuthi uyaconnecta ngomhla ka-31 siyohlangana khona madoda. Madoda.